So I was there for most of the session this morning, and it was an excellent session. And I hope that we do a great session as well in CAR T cells and what's in the present and future. So I'm going to start off by talking a little bit about the actual CAR T cell function, and then I know the other speakers are going to go into more details about the research that's going on and what's next for CAR T. Okay, so here are some topics. We're going to first talk about why do we need cellular therapy and what's the actual promise of immune therapy. Then we're going to dig in a little bit on what are these CAR T cells, what are some therapeutic agents that we can use, who's the best patient for these cellular therapies, and how are they different alike compared to T cell therapies. So why exactly do we need cell therapy in myeloma? As you guys all know, triple drug refractory patients are unmet medical need, right? There was a mammoth study that was done on patients who were refractory to CD38 targeted therapies. So they had 275 patients in 14 centers who progressed on anti-CD38 monoclonal therapy. These patients had a median prior range of therapy around 5, and 26% of them are penta-refractory, meaning they've had exposure to 2 PIs, 2 IMiDs, and an anti-CD38. And 249 of these patients went on to receive additional treatment, and the overall response rate to that treatment was 31%. So their median PFS was 3.4 months, and the overall survival is 9.3 months. So we know that after you've been penta exposed or triple refractory, it gets harder and harder to treat the myeloma. And that's why I know the first session was spent on transplant and your first treatment that you're getting to get a deep remission. So because of this, we need other therapies that we can actually target that gives us a better overall response rate in 30%, and which is where we're seeing with cellular therapy. So what exactly is the promise for this immune therapy? It's an immune response that selectively targets malignant cells, and it's a broad anti-tumor response that has the potential to target these different tumor clones, including particularly these malignant cells, as well as having an immune response that's potentially going to give us a memory and long-term surveillance, because we want to be able to give this therapy, but also see the benefit long-term. So what are some main targets for immune therapy, right? So in the past, we've had monoclonal antibodies, which is what we use a lot of, daratumumab. They directly target the myeloma cell surface proteins, and they recruit immune cells. And then we also have these to the right, the T cell engagers and the bispecifics, which we're not going to spend a lot of time on, but these are activating native immune cells that you already have to target the myeloma cells in your body. And then what we're going to primarily focus on is these CAR T cells, which are re-engineered myeloma fighting T cells. So the actual definition of the CAR is a chimeric antigen receptor. And these are receptors that are actually engineered to express on the surface of the T cell. So if you can look in this picture, which we'll have a video in a second, but you can see that these T cells are induced with a viral vector, and these CARs actually make a recognition of a tumor-specific antigen by the T cell and end up causing tumor cell death. So in the past, we've had first-generation CAR Ts, and as we're getting more and more familiar with CAR Ts and how they work, we have second-generation CARs and third-generation CARs where we're adding different co-stimulatory domains to make it more, make these T cells more persistent, but also not have as much toxicity. And so here's a video where it shows what the viral DNA is inserted into the T cells. You can see that the CAR is expressed, and now it's able to recognize this antigen on the tumor cell. It proliferates and expands and ends up killing the tumor cell, releasing cytokines and getting tumor cell death. So when you pick this, how do you pick your antigen? So you really have to make sure you have an antigen that's chosen to have minimal expression on normal tissue, right? So you want to have a CAR that's expressed, or the antigen that's expressed primarily on the malignant plasma cells. And so when you re-engineer these T cells and then they come into your body, they're attacking just the myeloma cells and not as much of your healthy tissue. Sometimes you can have unanticipated low expression of antigen in these normal tissues that can lead to some toxicities, like CD19, which is primarily used in lymphoma CARs and some myeloma CAR T cell trials. It's expressed on normal B cells, so then they could cause prolonged severe lymphopenia. There's another antigen called MAGE-A3, which is expressed on some heart tissue, so then you can end up getting cardiogenic shock. So what we know is that this is more of an immune-mediated response. So to attack this, if you have some toxicities, would be with steroids, but not with anti-cytokine therapy. But when we look at the targets, what targets do we really have for myeloma right now? And as you can see, the list here to the left, we have quite a few. Typically, what happens is as a patient gets apheresed and you're collecting their T cells. But at that time, right now, most of the CARs that we have are the autologous CARs where we're using your own T cells. But there's also in clinical trials, more in the early stages, are allogeneic, where you're getting it from a healthy donor or off the shelf CARs. And what we're doing is we're collecting T cells, but there's also other cell types that are in the market right now in clinical studies are NK cells, NKT cells, and these gamma delta T cells. Then these T cells actually get expanded, and then they get, as you saw, they get induced with viral vectors, and there's other alternative loading methods, and you basically make the CAR. And this CAR is then given back to you after giving lymphodepletion chemotherapy to wipe out the T cells that you have, so these engineered T cells can do their function. So in terms of the antigen targets, there's quite a few. And the ones that we're going to focus on today a little bit are the BCMA, CD19, and the GPRC5D CAR. A lot of these are still in clinical trials and ongoing, but this is some of the stuff where we have more data and some exciting things to look forward to that are coming up. So in terms of BCMA, why was it chosen as an antigen? It's because, as you can see in this figure, BCMA is expressed on late memory B cells that are committed to become plasma cells. And these are expressed universally on multiple myeloma cells. So if you can look here to the right, you can actually see these are all the different tissue types. And when we looked at it, BCMA is expressed mostly on plasma cells. You see that there's occasional some expression in the duodenum, a little bit in the lymph node, tonsil, the rectum, but primarily these are expressed in the plasma cells. And this is what we talked about earlier. We want to make sure we find an antigen that's expressed primarily on your malignant plasma cells and not as much on healthy tissues, so you can avoid the other toxicities. Another target that was studied predominantly in lymphoma trials, and we have commercially approved CAR T cells in lymphoma, are the CD19 CARs. They are also being studied in multiple myeloma in combination with BCMA, some slowly all by itself. They are expressed infrequently on myeloma cells. However, you can see that some multiple myeloma cell clones that have drug resistance or disease propagating properties, they do actually express this molecule. Another target worth mentioning, which you'll start hearing more and more about, maybe at ASH and upcoming, is GPRC5D. What it actually stands for is G protein coupled receptor class 5 membrane D. I know it's a big word. It's predominantly also expressed in cells with the plasma cell phenotype, particularly malignant plasma cells. Right now, GPRC has been in the studies for bispecifics, the T cell engagers, but also there are trials. I know MSK just opened a GPRC5D CAR T trial, and I know at Sinai we're in the process of opening another GPRC5D CAR T trial. And this picture actually shows you where in normal cells, you don't have any GPRC5D expression as you do in the malignant plasma cells. The one interesting thing about this is that it's also expressed in low levels, just like the BCMA, in lung, skin, testes, thyroid, some nail beds, salivary glands, and the brain cerebellum. So those are something that we have to just keep in mind when we are using these as CAR T products in patients. We have to make sure we monitor for those toxicities, which, since they're very low levels, we hope to not see very much toxicity. So in terms of the process of the CAR T, so we know kind of what happens to the CAR T cells when they're collected, but what happens to the CAR T as for a patient, right? So once you get selected to be on a CAR T cell trial, right now, since we don't have any commercially available CAR Ts, it would be as a clinical trial. So if you meet all the eligibility requirements, you undergo leukapheresis, which is when they collect your T cells. And then you have this gap between when your T cells get manufactured and they come back, right? And that gap varies anywhere from 4 to 5 to 6 weeks, where they have to be sent off to the sponsor. They're remanufacturing these cells and doing everything we talked about earlier before they get sent back to our site. So during this time, patients can get what's called bridging chemotherapy because if you remember, you have to be eligible for these trials, you have to be at least exposed to a PI, an anti-CD38, and an IMiD, and you have to be progressing. So if you're progressing and you're not on any chemo and you're waiting for 5 weeks, not everybody has the privilege of, what if your myeloma is progressing very quickly? So these patients undergo what's called bridging chemotherapy, where you can get some chemo to hold you over while your T cells are being made and given back to us. So then you undergo what's called lymphodepleting chemotherapy, where we talked about with usually fludarabine and Cytoxan for 3 days before your CAR T cell infusion. And what happens is we wipe out your T cells that you have, and then you generally get admitted into the hospital. Most of the myeloma CARs right now require admission and hospitalization for the infusion of CAR Ts. I know one of the trials is now studying outpatient CAR T, so this is something that could be done in the outpatient setting hopefully soon. So then you get infused with your CAR T cells. So what actually happens when you get infused with your CAR T cells? So these CAR T cells, what they do is they traffic to the sites of disease and they engage their antigens, right? So they try to find the neoplastic T cells, which are your myeloma cells. They proliferate and they rapidly, exponentially expand. And then these cytotoxic CD8 CAR T cells actually end up killing the tumor cell and release cytokines and other antigens. So in the past, we thought it was just the T cell attacking the cancer cell, killing it, causing the release of these cytokines, but we found out that these cytokines actually trigger your innate monocytes and macrophages to also cause more of the cytokine inflammatory response. So what actually happens when you have an excess of these cytokines? It can lead to fevers, it can cause some low blood pressures, it can cause you to have difficulty breathing. And these are all complications known as cytokine release syndrome. And there also can cause something called neurotoxicity. But what's interesting is with most of the myeloma CAR T cells so far, we've seen very low grade cytokine release syndrome that's easily manageable with these antidotes that we have, which are anti-cytokine therapies. One particular one is tocilizumab. So it's a monoclonal antibody that you give. And as you can see here, it basically is a receptor against the IL-6 receptor. It's a monoclonal antibody against IL-6 receptor where you're decreasing this cytokine from being elevated. And a lot of people worry, oh, well, if I give that, we get asked this question a lot, does that mean that my CAR T cells stop working? So what you can see is here that there's a lot of other cytokines that are also in your body that are still active. These CAR T cells are still doing the killing of the myeloma cells. You just kind of helped one cytokine. But if you have really severe toxicity, one thing you can do is give really high dose steroids if you really want these CAR T cells to stop proliferating so quickly. But most of the myeloma CAR T trials right now, very low rates of high grade cytokine release syndrome, really low grades of really low toxicities and neurotoxicity, and they seem to be very safe. So like we talked about the CAR T cell complications, the most important is CRS and neurotoxicity. You also have to consider you can have what's called tumor lysis syndrome, because if you think about it, these patients are getting bridging chemotherapy. You're kind of giving agents that they've already seen. So maybe the bridging is not working as well, and these patients have a high tumor burden going in. And when these T cells go in and start killing off the myeloma cells, you can have what's called tumor lysis syndrome, which you'd manage the same way you would in any other setting. Plus, if you remember, I mentioned you get 3 days of chemotherapy, cytoreduction chemotherapy with fludarabine and Cytoxan. So just like any chemo, if you get chemo, you know that you can cause cytopenias, meaning your white count to drop, your platelets to drop, and you can be at risk for infections. And then the last thing is the on-target off-tumor toxicity, which we talked about, if the tumor antigen is associated on, expressed on normal tissues. So understanding what the CAR T is and how it works, how do you know who the best option for the cellular therapy is, right? Like, how do you select the right patient for the right cell therapy? Because there's so many therapies out there right now. So one thing would be efficacy, right? So if you had efficacy, that'll really tell us what's an important driver in terms of your treatment choice. But as you know, most of these are in clinical trials. So some of the data is preliminary for these cell therapies, and it's really hard to compare one therapy against another therapy because they're very different. And most studies are still ongoing. So sometimes some of these trials, we don't really have the PFS data and the OS data yet. But what's your optimal time of thinking of cell therapy? Like when is a patient should think about cell therapy? When should they be referred, right? So when they have progressive or refractory disease, then they're potential candidates. But the one thing to keep in mind is early referral is better than late. So if you've already progressing and you have really rapidly progressive disease, and then we think about sending you to a tertiary center or an academic center where you're gonna have a CAR T cell therapy or even a clinical trial, for a bispecific or ADC, you have to understand if you're progressing rapidly and you have to wait 5 weeks, you know, you have to get enrolled on the trial, get your T cells collected, and then wait 5 weeks to get your cells back, you may not be the best candidate for CAR T. And you may want to consider off the shelf like bispecifics or something else that's easily something that you can get faster than waiting the 5 weeks. Therefore, early referral is always good. It's always good to just go to a center and then have them know, okay, well, you're on this therapy, you're doing okay, but if you're progressing, then this may be the time to come back so then we can get everything moving very quickly. Some other factors that really influence in terms of the right therapy for each patient is their frailty, their disease morbidity, their risk assessment, their treatment history, and their lifestyle. But the most effective regimen that's safe, but we want to find the most effective regimen that's safe and while maintaining your quality of life. So when you look at frailty and age, you know, this talks about age and comorbidities. If you have somebody that's old but that has a lot of comorbidities, are they a good candidate for CAR T? Understanding they may have that cytokine release syndrome. I know I mentioned that the toxicity is quite low and, you know, we don't see high grade CRS, but that's still a consideration that you would have compared to say a bispecific or an antibody drug conjugate option. But understanding that age is just a number, we've actually did a CAR T on a patient that's 79, right? But he's 79 with not a lot of comorbidities. He's very fit, very active. So I wouldn't be just put off by an age saying, oh, this patient is older, so they're not a good candidate. But like look at the age, but also their performance status and their disability and their comorbidities. The other thing is what we talked about is the refractory disease and their aggressiveness of their disease. If they're rapidly progressing, they have a lot of extramedullary disease, they have issues with their kidney, you know, and you don't think they can wait the 5 weeks to get the CAR T cell therapy. So let's give them something else to bridge it, make their disease burden a little better, and then consider them for a CAR T. They may do bispecifics in the meantime or some other T cell engagers. As the same thing as you want to look at, are they high risk? What previous therapies did they have? What their responses for certain therapies? And the last thing that's really important is patient preference and also family support. Because these cellular therapies are very intense. And so they do require a lot of family support. And maybe I had a patient that said, I didn't want to do a transplant. I wanted to do a CAR T. So we were able to get her onto one of the earlier line CAR T trials. But then I had a patient that said, no, I'm too scared of CAR T. I'd rather just come in weekly for infusion. It works for me. It's easier, right? So we have to see what the patient actually wants. And then the last thing is the family and social support is very key because for CAR T therapies, although relevant, most of these therapies require you to be hospitalized. So like for CAR T, I said, I know we're working on getting patients to do this outpatient. But right now, most protocols require you to be hospitalized for the first 14 days, anywhere from 10 to 14 days. And then you have to stay local to that institution for another 2 weeks. So total of a month, you need to be in a different center. Say if you're from North Carolina and you were coming from New York, coming to New York to get your CAR T, right? You have to find place to stay for 2 weeks after. Most of the clinical trials, the sponsor will cover your travel, but once it becomes commercially available, then we have to figure out how does that work. And then you have to monitor them very closely for, you know, the next 100 days to make sure they don't have any other complications and beyond. And for T cell engagers, you know, initially for the bispecifics, for the first few doses, they do require that you get admitted to the hospital for anywhere from 24 to 48 hours. Some of them is IV administration, some is sub-Q, but you do have to come every week for these therapies, right? So you need to make sure you're able to come in every week, you have somebody to bring you, etc. But in terms of when you compare the different immunotherapy approaches, I just wanted to touch base on it very briefly about the different options and broadly speaking, what's the difference between each of them. So you have the antibody drug conjugates, you have the CAR Ts, and then you have the bispecific or the T cell engagers. So in terms of off the shelf, ADCs and the bispecifics definitely are because you can get them right away. CAR Ts, not yet. There are some off the shelf CAR Ts in preclinical studies, but we're not readily available yet. And in terms of ease of administration, the antibody drug conjugates, you get an infusion once every 3 weeks. Bispecifics, you're coming in every week or every 2 weeks to get this treatment. Sometimes, like I said, you may have to get admitted. CAR T, fortunately, is a one-time treatment. Repeated dosing, so for the others other than CAR T, you do need to get it frequent dosings. We also have to see how the patient's T cell fitness is. So for CAR Ts and bispecifics, it matters more than the ADCs. And then the toxicities are pretty similar for the CAR T and the bispecific. However, with the bispecific, the CRS grades are much, much lower than even CAR T. And then also, are you seeing durable clinical activity? Right now, we're seeing in all of them. Like I said, the follow-up is very short and time will really tell us on what we can do. I mean, this is going a little bit more in depth on the different types of products and the pros and the cons. But the basic thing for CAR T is that you're seeing really unprecedented response rates. And it's a long chemo holiday. It's a one-time intervention, but there's a lot of cons, like we talked about, the manufacturing, the cytokine release syndrome. Some of these patients after have cytopenias and they have to get frequent transfusions until they recover. And then for the bispecifics, it's very readily available. It's off the shelf. You're seeing deep responses, but we have limited data in triple class and pentarefractory patients because, like I said, all these trials are very early and very new, but you do need to continuously administer them. And then the antibody drug conjugates, GSK's ADC just recently got approved. It's off the shelf. It's 1 hour infusion every 3 weeks, which is quite easy to handle. And there's no cytokine release syndrome associated with it. But there are some ocular toxicities where you do need to see an eye doctor before every infusion to make sure that there's not any eye changes due to the drug. So understanding all of these, there's quite a lot of therapies that are available right now for these relapse refractory, triple refractory unmet need. And we're very excited to see where the field is going. And that's all I have. Thank you.